information about immunization. So it will be very useful for all our pediatricians. Over to Dr. Somasundaram.
Thank you, sir, for this introduction. Good evening, respected senior office bearers, our Smart Clinic coordinator, National Coordinator, Dr. Sunil Srinivasan, Dr. Muthukumar, sir, our President, Dr. Sendil, Suresh Balan, sir, Ismail, sir, everybody. Thank you for this opportunity to present on this hot topic. Usually my presentation will be teleconsultation. So that will be in the middle order, usually will be in the middle order. So this, our captain and the coach, Dr. Sendil has given me this opportunity to bat in the last order. So I have to make success to win this tournament. So let me see this. So you have given me an opportunity to browse and update me on the hot topic, sir. Thank you for this opportunity. So going into the topic, we usually does this, update our mobile often, update and upgrade our car when there is ample opportunity for us. We update the software. We update lot of things in our day-to-day life. It's our duty to update on the latest guidelines on immunization, infection, and those things. If you have not updated and you are Dr. X, you and a patient from Dr. Y comes to you and asks for a vaccine. If you tell that that vaccine is not needed, either you will get a bad name or the Dr. X will get a bad name. So it is everybody in this country should be updated on the recent guidelines which is prevailing in this country, so that the patient will not be misguided and no pediatrician will get a bad name that he's unwantedly prescribing this vaccine, or he's not necessarily giving this vaccine. So every pediatrician should be a big pediatrician. Means a B for breastfeeding, I for immunization, G for growth and development. So he should be a big, if he wants to be a big pediatrician, he should be great in all these things, which include immunization. This is not my mnemonic. This is from Dr. Pramod Jog's lecture. So I used to hear this his lectures, and I have taken this mnemonic from him. One of my teachers way back in 2003 used to tell me, pediatric practice should have bun, butter and jam. Your bun is only your OPD practice. Your butter is if you have an IP practice also. The jam will be the immunization. So to bring you monetary benefit also, you should have a good immunization practice for which you should be updated on the recent schedules. Which was the previous guidelines which we were all using? You must have either have a soft copy of this or a hard copy on your table. The IAP Guidebook of Immunization 2018-2019, which was prescribed after our teacher, Dr. S. Balasubramaniam, has taken over as the advisory committee chairperson. This committee was between 2018. It is a committee for 3 years from 2018 to 2020. So 2018, they worked for the 1 year and came up with this guidebook. Now it is the end of the tenure. They have updated the guidelines and they have given us. So this is the recent update 2020. So this has come as a hot cake to all our mobiles in the first week of December. And today we are presenting it. We have just got into it and then topic it. So this is for our president, who is a Tamil Vallunar. Palayana kalidalum pudiyana pudalum valuvala kala vahinale. So we have to change the guidelines. பழசா இருக்கிற கைட்லைன்ஸை புதுசா எடுத்துட்டு வரணும். மாற்றம் ஒன்றுதான் மாறாதது. என்னைக்குமே மாற்றம் இருந்துகிட்டே இருக்க வேண்டும். So why this update has happened? There are new developments in vaccinology. Few doses have to be deleted. Few doses have to be added. The time schedule for few doses have to be changed. So all these are developments in the vaccinology which has made up this change in the update. And the second thing, there are availability of new vaccines have come in the past 2 years. So they have to be incorporated, which DCGA has given the guidelines, DCGA has approved. So the guidelines has to be updated. What are the updates in the present 2020 update guidelines which has reached our mobile? There are 4 major changes and 5 new vaccines has been added. So this is the crux of the issue. What are the changes? The first change is injectable polio vaccine. Everybody will be perplexed. We are not having injectable polio vaccine. What I am to do? There is no standalone injectable polio vaccine with me. Previously, I have seen this carton which is coming to my memory. PolioVac PFS, Pol Protect, They were all there 5 to 6 years before, but they are not there. Because when government switched over from trivalent to bivalent OPV and told that poliovac is very, very important, all these stocks have become dearer. Now what we have is in private sector is only a combination of polio vaccine, injectable polio vaccine. We don't have a standalone polio vaccine as of now in the market. So, but what is IAP recommending? Booster dose of injectable polio vaccine at 4 to 5 years is mandatory. So this is the thing which is highlighted. 4 to 6 years, you should give an IPV containing vaccine. So if IPV, standalone IPV is not possible, can I give the bivalent OPV which is available with me? No. A booster dose of IPV at 4 to 6 years of age for children who have received the initial IPV doses as per the IAP schedule. Even if they have received the initial IPV doses also, the 4 to 6 years polio should not be an OPV, it should be an IPV. In case of non-availability of standalone IPV, this dose can be administered as a combination with the DTP vaccines. So that is the case now. So friends, it is our duty to give IPV because we are always in the risk of getting a new polio case. We are sharing our border with Pakistan. Pakistan is still an endemic country for polio virus. Lot of country in the Southeast Asian region are still not declared polio free. So we are always at the risk of getting a polio. So we are still using bivalent polio. So the third viral strain is still not protected in the recent for the children born in the past 4 years. So what are the options available for me at 4 years, 4 to 6 years of booster? You can either repeat your Infantrix Hexa, which is available. You can give a tetraxin, which has been recently introduced in the market, which contains full dose DPT and IPV alone. So if this is possible and this is available in the market, this will be the first option. And this will be the second option if the patient is affordable, is okay for a fever, which is a whole cellular vaccine. If the patient was an acellular vaccine, go for Infantrix Hexa. So these are the options available. Not to be used. Never use this Adacel and Boostrix, which are available in the market, which contain reduced dose of diphtheria. They are not going to mount an adequate response. They are to be used only after 7 years of age as per our academic IAP recommendation. Coming to the change 2. IPV is mandatory in the primary schedule. Now we have seen IPV as part of the 4 to 6 years. Now it is the primary schedule. No child should be left without giving at least 1 dose of IPV because IPV only contains the 3 polio viruses. So you should give all the 3 polio viral strains. Which is the most preferred option? OPV at birth, 3 doses of IPV at 6, 10 and 14 weeks and IPV booster at 18 months and 4 years. You can be very, very comfortable if you are given the schedule. You are supposed to give only 1 OP dose, that too at the delivery hospital only. Rest all should be IPV. So this is the best option which is available. If the patient is affordable for all the IPV doses, give the schedule which is available in the private sector. Second option, it is the UIP schedule or the government sector schedule. What is the government sector schedule says? Give bivalent polio at birth, 6 weeks, 10 weeks and 14 weeks. In addition to that, give 2 doses of fractional IPV. Because government is not able to afford full dose IPV for all the kids. So what government is doing is, it is giving fractional IPV. What is fractional IPV? 1/5 of the dose of the normal vaccine. So it is 1/5 of the dose of the normal vaccine. If it is given intradermally, it is able to mount the same seropositivity. So government has studied the schedule and it is giving this schedule for all the babies born in the government sector or born in the private sector and going to the government sector for vaccination. So look into the schedule. Third option, the baby is not affordable for a combination vaccine, either a wholesale vaccine or an acellular vaccine. What is the third option available? Give bivalent OPV at birth, 6 weeks, 10 weeks, give a full dose IPV at 14 weeks. We know that full dose IPV is not available, so you have to stick on to the combination vaccine which is available in the market. So this is the least possible option which is available. The not to be used at all, don't give a OPV and pentavalent which we were using previously. This is the worst crime you can do for a child. Bivalent OPV and a pentavalent vaccine for all the 3 doses of the 6, 10 and 14 weeks should not be used. If hexavalent vaccines are unaffordable or unavailable, the infant must be referred to the government healthcare facility for the primary immunization as per the schedule. This is the same words which is given in the update. So send it to the government healthcare facility because at least they will get the IPV. Don't send the child with OPV and a pentavalent vaccine. So clear about IPV. Now coming to the influenza vaccine. Nowadays, you have seen in the market that 0.25 ml of this flu quadri is not available. So what they are doing, update has changed because most of the vaccines are coming only in 0.5 ml composition. So what does the old guideline say? Old guideline says less than 3 years, that is between 6 to 35 months, use 0.25 ml. Above 3 years, use 0.5 ml. So we used to use Vaxigrip Junior, Flu Quadri Junior, or something like. So now what the latest guidelines say? Uniform dosing schedule of 0.5 ml above 6 months of age. Previously, they thought the reactogenicity, the febrile episodes are more if you give the 0.5 ml at 6 months to 3 years of age. Now they have found that the immunogenicity and the efficacy is more if you give the 0.5 ml itself from 6 months of age. So give the 0.5 ml itself, which is available in the market from most of the manufacturers from 6 months onwards. Don't discard the solution or try to get 0.25. But what they have given additionally is only 2 brands, that is Fluarix Tetra from GSK and Influvac Tetra from Abbott, have got the DCGA approval for the uniform dose. Still, the other brands are yet to get the uniform approval for the uniform dose. So stick on to these vaccines if you are immunizing a child less than 3 years of age. Reinforcing the schedule, you must know that flu vaccine is a mandatory vaccine as per IAP schedule from 2018 onwards. Annual flu vaccine is mandatory from 6 months to 5 years onwards because IAP considers this as the high-risk group. Given before the monsoon season every year, up to 9 years, it is 2 doses at 4 weeks interval when given for the first time. If you are vaccinating a flu vaccine for the first child at 3 years of age, give 2 doses. If it is given in the newborn period, the infancy, that is 6 months itself, then they must have finished the 2 doses, then stick on to only 1 dose every year. So this is about the flu vaccine. Coming on to the fourth change, that is in the varicella vaccine. So previously, you must have seen only 1 dose varicella. When I was in the postgraduate period and all, I myself took only 1 dose of a varicella, and the second dose was introduced between 4 to 5 months of age. Now, what they are saying, the second dose has to be preponed, given 3 months from the first dose. So that is the schedule. The second dose of varicella vaccine should be preferably administered 3 to 6 months after the first dose. What they feel is, after the first dose, only about 80 to 90% seropositivity occurs, and rest of the 20% are prone for infection at 3 to 4 years of age when they enter the school. So they want to give the complete protection for the child earlier itself. So they have postulated that an earlier second dose will be beneficial over a delayed second dose. So friends, stick on to a varicella vaccine 3 months after the first dose. Probably when the child is coming for a second dose of hepatitis A, you can give the second dose of varicella vaccine also. Coming to the addition. Yeah, there are few additions. A conjugate meningococcal vaccine, that is Menveo by GSK. So this is Menveo, which is a conjugated vaccine with CRM 197. So this vaccine can be used in place of other conjugate vaccine which are available. It's recommended in 2 to 55 years of age. So this is a quadrivalent ACWY is available. There are few polysaccharide vaccine which I am not going to touch. This is also a monovalent conjugate vaccine which is not produced by Serum Institute of India, but it is not available in India and it is available only in the African country. The other meningococcal vaccine which is available in the Indian market and the conjugate vaccine is ACWY. It is conjugated with the diphtheria toxoid, and the speciality of this vaccine is DCGA has approved this vaccine from 9 months onwards, and Menveo has been approved from 2 years only, even though it is a conjugate vaccine. The second addition is a second typhoid conjugate vaccine, which is Typhim BEV, which is from biological events. 25 microgram of VI antigen conjugated with CRM19. So this is also approved from 6 months to 45 years. Difference from typhoid TCV, not major difference. Only the bacteria which is conjugated is different. Monoclonal antibody for rabies that is TwinRab, which is produced by Zydus Vaxicare, has been introduced, and they have IAP has included and approved this for the post-exposure prophylaxis, but it should be used in category 3 bite only, should be used along with the vaccine for post-exposure prophylaxis. The fourth addition is a DTAP IPV combination vaccine, which I already mentioned in the previous slides, for 4 to 5 years booster. So this is a fully liquid vaccine recommended for booster between 4 to 6 years of age. You can use this vaccine, which contains full dose DPT and IPV. The last addition is our own Serum Institute, an indigenous pneumococcal vaccine. So IAP has approved this vaccine. This is a WHO pre-qualified vaccine, which has been in the market, which is about to come to the market a year ago itself. But because of multiple COVID situation and those things, it is still pending. A low-cost vaccine, same dosing schedule as Prevnar and Synflorix, which is available, but the serotypes are a bit different. So this is the serotype pattern of Pneumosil, and this is the serotype pattern of Synflorix. To be precise, what they have done is they have removed 4 and 18C from Synflorix and included 6A and 19A, which is available from the pneumococcal 13 vaccine. They used to say 3A, 6A, and 19A are very, very important for India, and PCV10, the Synflorix, doesn't contain 6A, 3A, and 19A. So why you should go for Synflorix? Now, Pneumosil has added 6A and 19A, so I believe this should be advantageous. Still, we don't know what is the price of this vaccine for the Indian market because it is yet to be launched. So points to pointer. A booster of the injectable polio vaccine is recommended at 4 to 6 years. Importance of IPV in the immunization schedule should be re-emphasized for the primary schedule. Uniform dosage of influenza vaccine recommended all children older than 6 months, that is 0.5 ml. Second dose of varicella should be preferable